This is Scott Norris, and I'm going to be discussing our chapter, Functional Imaging and Movement Disorders by Scott Norris and Joel Perlmutter. This presentation highlights key points from our chapter, including our primary objective to provide an overview of advanced neuroimaging tools and applications in the field of movement disorders. We emphasize the role of functional neuroimaging in understanding the pathophysiology of disease. We additionally caution the reader regarding potential confounds of neuroimaging methods that may affect interpretation of data obtained using such techniques. We then discuss potential future applications of functional neuroimaging in movement disorders, specifically in context of neurosurgical intervention. Molecular neuroimaging tools, including positron emission tomography, also known as PET, and single photon emission computed tomography, also known as SPECT, provide tomographic images of the regional distribution of administered radiopharmaceuticals. While SPECT is often more accessible and economical, PET reflects higher anatomic resolution and ability to quantify results. A key assumption in PET-SPECT imaging is that local metabolism or blood flow reflects local interneuronal activity or inputs into that brain region. PET or SPECT radiopharmaceuticals can target neuroreceptors, transporter molecules of various neurotransmitters, second messenger signaling mechanisms, or protein deposition. The text provides examples of each of these. One must recognize that some radiopharmaceuticals might be displaced by variable levels of endogenous neurotransmitters or treatment with competing medications. This is a potential confound of interpretation that must be accounted for in the interpretation of PET or SPECT studies. In movement disorders, molecular imaging is commonly applied to the striatal dopaminergic synapse. This dopaminergic synapse is critical in the pathophysiology of many movement disorders, including Parkinson's disease. This figure, 106-1 from our text, reflects a schematic representation of a striatal dopaminergic synapse. This demonstrates common PET radioligands and specific binding locations. A commercially available SPECT radioligand targets dopamine transporter, or DAT, via the radiopharmaceutical C11-CFT. Additional radiopharmaceuticals have been applied in research applications to measure various presynaptic molecules, including the vesicular monoamine transporter 2, or VMAT2, via C11-DTPZ, and the aromatic acid decarboxylate, AADC, via 18F-fluorodopa, or FD. Alternatively, one might target specific dopamine receptors on the postsynaptic striatal neuron. In this example, carbon-11 labeled raclopride specifically targets D2 receptors. In applying radiotracers targeted to such specific molecules, one can infer integrity of various striatal neurons using molecular imaging techniques. An example of molecular imaging applied in movement disorders is demonstrated in Figure 106-2 from our text, where we display PET imaging in patients with Parkinson's disease. In this figure, hot colors, or red, orange, yellow, reflect higher levels of fluorodopa uptake. On the left is a normal healthy control with good bilateral putaminal fluorodopa uptake. In the middle is a PET scan from an individual with mild Parkinson's disease, which demonstrates reduced fluorodopa uptake in the left putamen compared to the right. Finally, on the right is a PET image from an individual with moderate Parkinson's disease, demonstrating diffuse loss of fluorodopa uptake in the bilateral striatum. These images reflect the ability to monitor disease progression using molecular imaging techniques, a neuroimaging representation of damage to the nigrostriatal pathways in Parkinson's disease. While molecular imaging of dopaminergic neurons may help differentiate degenerative Parkinsonian syndromes from normal controls and Parkinsonian syndromes without dopaminergic deficit, such as essential tremor or ET and some dystonias, there remain additional potential confounds to interpretation of such techniques. A key question in the context of this textbook is whether neuroimaging sufficiently and reliably aids selection of surgical candidates. Figure 106-4 from our text demonstrates a pie graph of the distribution of the final diagnosis of 30 people in a single study with normal SPECT DAT scans. This figure demonstrates a false negative rate for degenerative Parkinsonism in greater than 30% of participants, demonstrating poor diagnostic accuracy of DAT SPECT. This is critical to understand in the selection of potential surgical candidates and/or targeted brain regions, where even normal molecular imaging scans may not provide reasonable security that a person does not have PD or Parkinson's disease. On the contrary, reduced dopaminergic integrity may occur in numerous Parkinsonian disorders, including those that lack evidence of response to surgical intervention, including multiple systems atrophy, MSA, vascular Parkinsonism, cortical basal degeneration, CBD, or progressive supranuclear palsy, PSP. There are no data to currently suggest that molecular imaging can differentiate these disorders from idiopathic Parkinson's disease. While surgical intervention is consistently demonstrated to benefit patients with the latter, patients with other neurodegenerative Parkinsonian conditions carry little or no benefit from neurosurgical intervention, which frequently results in overall increased morbidity and mortality. Another advanced neuroimaging technique commonly applied to study movement disorders includes magnetic resonance blood oxygen level dependent imaging, or MRI BOLD. This technique is often more widely available and avoids ionizing radiation. BOLD signals reflect a weighted ratio of oxyhemoglobin and deoxyhemoglobin that reflects regional differences in cerebral blood flow to delineate differences in regional brain activity. BOLD imaging can be obtained when a participant is performing a task or is subjected to an external event. One can then determine changes in brain regions that occur in relation to the task or event. MRI BOLD studies can be confounded by unintentional movements or unaccounted variations in approach to the task during scan acquisition. This is particularly germane in patients with movement disorders in which unwanted movement during scan acquisition can result in misinterpretation of findings. Unaccounted movement during scan acquisition can confound interpretation of the measured brain response and must be carefully accounted for in interpretation of any functional neuroimaging study. Resting state functional connectivity MRI methods avoid task-based confounds. Such studies also depend upon detection of BOLD signals, but in this case with the participant at rest in the MRI scanner during data acquisition. The concept of this advanced technique is that even at rest, brain regions communicate in networks that have high correlations and fluctuations of BOLD signals over time. One can thus study integrity of various resting state brain networks in various movement disorders. Figure 106-3 in our text demonstrates an example of resting state functional connectivity BOLD data using a seed-based analysis. In this technique, one can seed any number of brain regions and identify all other brain regions that have correlated activity at rest with that seed region. In this example, seeds are placed in the intraparietal sulcus, IPS, posterior cingulate, PCC, and medial prefrontal cortex, MPF. One can then observe in the functional connectivity MRI time series data of these regions that BOLD signals in the PCC, yellow, correlate with those in the MPF, orange, and anti-correlate with the IPS, blue, in normal control subjects. Application of resting state functional connectivity MRI allows the study of complete neural networks that might represent nodes that respond with greater efficacy and reduce side effects following surgical intervention in various disorders. In our chapter, we describe 4 potential future applications of advanced neuroimaging in movement disorders. First, to improve application of non-invasive neuroimaging tools in clinical diagnostic accuracy, with a specific emphasis of more accurately defining good surgical candidates. Second, advanced imaging allows for more precise determination of the relationship of structure and function in response to surgical interventions such as deep brain stimulation, which might allow for improved targeting and/or understanding regarding the pathophysiology of disease. Third, functional neuroimaging allows opportunity to study complete neural networks in search of nodes that may respond to surgical intervention with greater efficacy and reduced side effects in various disorders. Finally, molecular imaging may identify brain regions with specific neurochemical deficits, including the presymptomatic state. Such regions may serve as future regions for neurosurgical restorative intervention. Functional neuroimaging with either molecular imaging or MRI BOLD methods provides important new insights into the pathophysiology of Parkinson's disease and other movement disorders. The clinical role of these techniques remains an evolving frontier, but there remains much appeal to applying methodology as soon as possible to help patients. Such cutting-edge methods place burden on clinicians and expert scientific advisors to ensure adequate validation of methodology and potential applications that support clinical implementation. Despite our cautions, the potential of dramatic advances remains.